Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of actually inviting to the podcast the guest editors of the 2026 special issue. We're really very excited to discuss this special issue. It's an important topic on de-escalation of treatment in gynecologic oncology. And this year we had three very special guest editors, and I'll start by introducing Dr. Alex Melamed, who is in the Division of Gynecologic Oncology in the Department of Obstetrics and Gynecology at the Massachusetts General Hospital in Boston, Massachusetts. Alex, welcome to the podcast. Thank you so much for accepting the invitation to be a guest editor on this special issue.
It's a great honor, and thanks for having me again, Pedro.
Of course. Next, I'll introduce Dr. René Pareja, who is also an associate editor for the International Journal. He's at the Instituto Nacional de Cancerología in the Department of Gynecologic Oncology in Bogota,
Mhm.
Colombia. Really very excited to have you. He's also at the Clínica Astorga, Department of Gynecologic Oncology in Medellin, Colombia. René, welcome to the podcast. And once again, thank you for participating as a guest editor in this really unique and special issue.
Thank you for having me, Pedro. It has been a honor doing my job.
Excellent. And lastly, I'm going to also introduce, and unfortunately, she could not join us for this podcast, Dr. Gretchen Glazer at the Mayo Clinic, Department of Obstetrics and Gynecology, Division of Gynecologic Surgery in Rochester, Minnesota. And Gretchen, thank you so much also for participating in this special issue. Certainly, we look forward to speaking with you soon as well. All three of you, fantastic job. Really, I commend you for all of the work, the effort, the time that you have devoted to putting together this special issue. Lots of topics to cover, and I'll start with you, Alex. First question about this issue on de-escalation. There were many topics that have been covered. And we'll start with this one. Your review highlights how limited and heterogeneous the existing evidence is, particularly regarding oncologic outcomes and patient-centered endpoints. In this context, how should clinicians balance guidelines recommendation with the uncertainty reflected in the current literature?
Yeah, I think Pedro, you sent me these questions before, and this is related to an article about sentinel lymph nodes compared to other forms of nodal assessment in endometrial cancer. And I think that uh, I agree with the assessment of the article. I think there's a limited and heterogeneous evidence. My practice is basically to offer sentinel lymph node mapping and biopsy to all patients with endometrial cancer. But I know that that is not everybody's practice and not the recommendation of every society. I think on the side of more escalation, there are those who believe that patients with high risk histologies, for example, benefit from comprehensive lymph node staging. And on the other side, I think there's those who believe that we really don't have any evidence to support surgical lymph node staging in anybody. So I think all of those arguments have some degree of merit. Myself, I think that sentinel lymph node mapping and biopsy is a kind of a down the middle approach. Which is a good compromise between getting the most reliable lymph node information to guide adjuvant treatment and to be able to apply the existing clinical trial evidence to my patients while avoiding the additional morbidity associated with complete lymphadenectomy in this disease.
Excellent. Great start to this discussion. And also on the same article, this question also from Vincenzo's Tarantino at Gemelli, one of our fellows now in the journal. And I'll turn over to Renee. And he's asking, one of the striking findings in this review is not a clear difference between strategies, but rather how heterogeneous the comparative data are actually in the literature. From your perspective, what are the main misconceptions clinicians may have when comparing sentinel lymph node biopsy with no nodal assessment?
Thank you, Pedro. When comparing sentinel node biopsy with non-nodal assessment in early-stage endometrial cancers, clinicians often combine the two as equivalent low morbidity approaches. Unfortunately, this is a misconception because sentinel node biopsy is an active staging strategy that can detect occult nodal disease through targeted mapping and ultrastaging, whereas non-nodal assessment simply assumes nodal negativity. Imaging and uterine risk factors alone do not reliably exclude nodal spread, even in low-risk cases. Sentinel-node information improves prognostic accuracy, refines adjuvant treatment decisions, and does so with minimal added morbidity. In contrast, omitting nodal assessment accepts diagnostic uncertainty rather than avoiding unnecessary interventions.
Excellent. So I want to turn now to the topic of adjuvant therapy. And there's an article that talks about avoiding adjuvant radiotherapy in the intermediate risk endometrial cancer. This question comes from Lucia Rivero at the European Institute of Oncology. And she's asking, in your day-to-day practice, um, how do you integrate molecular classification with traditional clinical pathologic factors when deciding between observation, vaginal brachytherapy, or pelvic radiotherapy across intermediate and high risk intermediate endometrial cancer?
Yeah, I mean, I guess what I would say, and maybe this makes me, old-fashioned, but my feeling is we don't really have the trials to support at this point modifying our adjuvant approach based on the molecular classifications, and so one way that I might is, we have at my institution clinical trials that are open to patients based on molecular classifications. And certainly, I would recommend and enroll patients onto trials such as the Rainbow trial. But when it comes to standard of care therapy, I'm very loath to modify, particularly very loath to de-escalate my adjuvant treatment approach based on molecular classifications. The question that I still think is unanswered is, do POL-E patients do so well because, they have a good prognosis no matter what you do? Or is it simply that POL-E patients are more sensitive to treatment, And I think either one of those could be the explanation for their overall very good outcomes. And until we know which one that is, I'm not comfortable de-escalating even for POL-E patients.
Yeah, excellent, excellent points. And I'll turn Renee to you, Lucia Ribeiro, also asking, current European guidelines and the PORTEC 4A trial integrate additional biomarkers, estrogen receptor status, CT and NB1 mutations, L1 CAM expression, to better individualize adjuvant radiotherapy. Since these biomarkers were not addressed in this particular manuscript, which do you see as most promising for refining radiotherapy decisions in this same patient population, intermediate and high intermediate endometrial cancers, and why?
I would like to thank Lucia for this question. Among the biomarkers that you mentioned, L1CAM is likely the most immediately promising for refining adjuvant radiotherapy decisions in intermediate and high-risk endometrial cancer. It is widely available by immunohistochemistry and consistently identifies aggressive biology and higher recurrence risk, even with otherwise intermediate risk groups, making it particularly useful for treatment escalation decisions. That said, the greatest clinical value probably comes from resolving heterogeneity within the NMSP subgroup, as proposed in PROTECT 4A. In this context, CTNNB1 mutations help identify higher risk tumors with deceptively favorable histology, with estrogen receptor status supports de-escalation in the more indolent hormone-driven disease.
Excellent. Now let's turn to an article titled "Key Considerations for Safe De-escalation of Therapy for poly-mutated endometrial cancer. And Alex, you alluded a little bit to this before. This question comes from Giuseppe Parisi, also at Policlinico Gemelli, and he's asking, ESGO Estro ESP 2025 labels FIGO 2023 stage 3M and 4AM poly-mutated endometrial cancer as an uncertain risk group and states that no firm adjuvant recommendations can be made. Although tumor board de-escalation from high-risk therapy may be considered, in your tumor board at your hospital, what minimum criteria would you require to de-escalate, and which hard stop red flags would make you treat these patients with full-on intensity multimodal therapy?
Yeah, so I have to stick with my answer, and this isn't just my answer. This is our practice at Massachusetts General Hospital. We are generally speaking not de-escalating. Now, it may, there are patients who you really don't want to give adjuvant treatment to, not because of their cancer, but because of their potentially their comorbidities or their strong preferences. And in those edge cases, I could imagine perhaps knowing that someone had a poly mutation, helping support that kind of non-standard of care decision. But as a general practice, we are not currently de-escalating care for poly mutated patients. We are anxiously awaiting the evidence that would support doing so.
Yeah, changing strategies. That's right. So I'll go to you, Renee, on the same article. Question is, because the favorable polymutated prognosis is thought to be largely immune mediated, how should we approach de-escalation in immunocompromised patients? Is this a subgroup where you would avoid omission of adjuvant therapy? And what surveillance or treatment modifications would you consider? So somewhat of a unique patient population.
Yeah, that is an interesting question, Pedro. In polymutated endometrial cancer, the de-escalation is generally justified by an excellent prognosis that is partly immune mediated, but this assumption warrants caution in immunocompromised patients. In this group, I would be more conservative and avoid automatic omission of adjuvant therapy, particularly when additional clinical pathologic risk factors are present. The degree, duration, and reversibility of the immunosuppression should be considered as risk modifiers rather than an absolute contraindication to the escalation. Enhanced surveillance with shorter imaging and clinical follow-up intervals is reasonable, and treatment decisions should be individualized through multidisciplinary discussion, balancing oncological and safety against treatment-related morbidity in this group of patients.
Very well. So now we're going to turn to a different patient population, that younger premenopausal patient population with endometrial cancer. An article titled Updates in Evolving Care Paradigms for Premenopausal Patients with Endometrial Cancer. Question comes from Anusha Kamath in India. And she's asking, can you comment on how clinicians can use molecular profiling when deciding on fertility management options? And if you feel one should wait for lesser time before waiting for treatment response in certain conditions.
Yeah, I mean, I think this is a good point. I think that again, this is an area with great uncertainty, as with all our data on fertility sparing management. Clearly, we have much less data than we do in conventional management. One thing that seems clear to me is that if someone has a P53 mutation in their tumor, it makes me very uncomfortable to try conservative management. So that is a way in which I think I might modify. So even someone who otherwise looked like a good candidate, perhaps by histologic type and grade and depth of invasion, the presence of P53 would certainly make me think twice about that. Another molecular category that some of my colleagues have considered as a contraindication is folks with Lynch syndrome or MMR deficiency. And I think the data on that is mixed. Certainly, there's evidence of a lower response rate to hormonal treatment, but I don't think that the response rate is zero. And given the prognosis of these patients is intermediate, compared to no specific mutation patients and P53 patients, I think it's that might be a group in whom you might consider, more aggressive surveillance and have a lower threshold for cutting bait and saying, look, it's not working.
Excellent. Yeah, very, very good point. And then particularly again, a unique patient population. Staying on that same topic, another interesting question with regards to how to approach it, right? This one, she's asking, is there any evidence that hysteroscopic resection alone may suffice without adding progestin in patients with a grade 1 with no myometrial invasion? So just plain old resection.
Yeah, Pedro, at present, there is no high quality evidence to support hysteroscopic resection alone as sufficient treatment for FIGO grade 1 endometrial cancer without myometrial invasion. While small retrospective series suggest that complete hysteroscopic tumor resection may reduce disease burden, most favorably outcomes in fertility sparing management come from protocols that combine hysteroscopic resection with progestin therapy. Progestins likely treat residual microscopic disease and address the hormonally driven biology of these tumors. Omitting progestins remains experimental and should be limited to clinical trials or highly selected cases with intensive surveillance, as hysteroscopic resection alone cannot reliably ensure durable oncological control.
Great. So now let's move over to ovarian cancer. Article titled De-escalation in stage 1C epithelial ovarian cancer adjuvant treatment. Alex, the question comes from Beate Sarta in Latvia. And her question is for the subgroups where you consider de-escalation reasonable, meaning stage 1C grade 1 endometrioid, low grade serous, expansile mucinous ovarian, and possibly stage 1C1 clear cell ovarian. What specific factors would make you still recommend adjuvant chemotherapy?
Yeah, this is a topic that I have strong feelings on, as any of the fellows at my institution will tell you at Tumor Board. I think this is a great topic because I think it's an area of controversy, and I did solicit this article from a great gynecologic oncologist that has written a lot in this area. Personally, the only 1C ovarian cancer that I really think is a good candidate for de-escalation is 1C1, so surgical spill. We think that
Mhm.
the prognosis of 1C1 is similar enough to patients who are 1A or 1B that I think it's reasonable to omit treatment in these patients. I am not in favor, actually, of omitting chemotherapy in any of the histologies mentioned for 1C2 and 1C3. And the reason for that is that if you go and you look at the subgroup analyses of the Action Icon combined paper, the paper that combines the two randomized trials that were done looking at adjuvant therapy for early stage ovarian cancer, even though you might expect that the effect of the treatment is greater in high-grade disease or less, for example, in mucinous, right, based on our sort of preconceptions about what is or what isn't chemosensitive, what you find is that's absolutely not what the empirical data shows. So it appears very much in that study that adjuvant chemotherapy works in mucinous cancer and works in low-grade disease. And so I personally do not favor de-escalation. I do think that there's enough controversy in these based on the observational data that is cited in this paper to do a de-escalation trial in these populations that are mentioned. So looking at, 1C1, 1C2, and 1C3 mucinous cancer and saying, do they really need it? But until I see such a trial, I am not in favor in de-escalating in these patients because I think think that in fact, in these diseases, actually, the one-time chemotherapy might work is in the adjuvant setting, where we know that it is pretty ineffective once patients actually have bulky disease.
Well, thank you so much, obviously, for taking us through your very well articulated answer. And I can tell there's a lot of passion in that and behind this topic for you. And thank you, actually, for seeking this particular article and this topic. So, with that, then I'll turn over to Renee, still on this same topic. And the question is, looking ahead, do you think decisions for stage 1C endometrioid ovarian cancer will still be driven mostly by histology, or are we moving toward molecular subtype becoming the main way to decide on adjuvant chemotherapy?
Thank you, Pedro. I think histology grade will remain important in stage 1C endometrioid ovarian cancer, but it will be no longer be the sole driver of adjuvant treatment decisions. We are clearly moving towards molecular subtype as a key modifier of risk, helping us distinguish tumors with truly aggressive biology from those that are likely overtreated with chemotherapy. Alterations such as mismatch repair deficiency, poly-like features, or hormone receptor expression may increasingly support de-escalation in selected patients despite stage 1C disease. In practice, the future unlikely to be great versus molecular profiling, but rather an integrated model where molecular features refine and sometimes override traditional histopathologic risk factors.
Excellent. So, Naya Seminario from Vallebron in Barcelona, in Spain, she'll take us into this next article titled Challenging the Standard in Early Stage Ovarian Cancer, Current Evidence in a Standardized Framework for Sentinel Lymph Node Mapping. And she asks, regarding the pelvic sentinel lymph node detection, do you think there will be an acceptance of a double injection site, cervical injection for pelvic lymph nodes combined with an ovarian ligament injection for para-aortic nodes as a research standard? Or do you believe that a single injection site option could still be considered in the future? In this context, considering that most data on pelvic lymph node detection with cervical versus uterine-ovarian injection come from endometrial cancer, do you think cervical injection could become a standard strategy to improve pelvic detection in ovarian cancer? Or should it always remain complementary rather than substitute? A long question. I know that Naya tried to cover a lot of topics in that, and I would add to that question, do you think there is a future role for sentinel lymph node mapping at all in ovarian cancer?
Well, I think it's an exciting area of research, right? I don't think we're there, and I don't know if it's going to work, but it clearly works in endometrial cancer. It clearly works in cervical cancer, and it clearly works in vulvar cancer. And so I think the interest in ovarian cancer makes a lot of sense. Obviously, there are unique challenges, and I think the fact that the ovaries drain in two different directions lymphatically, is a little bit different. It's a little bit of a challenge. I think every one of our other sites seems to have one sequential path that it drains, be it through the inguinal to the pelvics for vulvar cancer, or through the pelvics to the periaortics, right? I think this approach in ovarian cancer, therefore, where you do two separate injections, is very interesting, and I think that I think as a research direction, it is very promising. I am going to withhold judgment until someone figures out how you actually even do a good study to study this. But I think it's interesting, and I'm glad that it's a direction in which we're working, because I do think doing a whole pelvic and periaortic lymph node dissection is morbid. It's clearly morbid. We know it's morbid, and so if there's a way to decrease that morbidity while still getting the staging information that we want, I think that would be very exciting.
Great. And this next question is for you, also from Naya Renee. And she's mentioning, it's mentioned in this article that the best results in ovarian cancer sentinel lymph node mapping come from expert centers, which personally I don't know how that is defined, or single high volume surgeons, another term that I personally don't know how that is defined. And the CELI trial demonstrated significant inter-center variability based on your experience. What practical strategies, such as case volume, structured mentorship, local quality assurance, are needed to shorten the learning curve and ensure that sentinel lymph node mapping in ovarian cancer is reproducible and safe in lower volume hospitals or in settings without routine access to nuclear medicine?
Pero I don't know what is an expert center. We can suppose that the expert centers are those who publish in the issue and who run the trials on sentinel node detection in ovarian cancer. In my experience, safe and reproducible ovarian cancer sentinel lymph node mapping outside expert centers requires deliberate system building rather than individual enthusiasm. A minimum case volume is important, but volume alone is insufficient without a structured mentorship, ideally through proctorship or mentorships in experienced centers. Standardized protocols for tracer selection, injection sites, which is the critical issue here, and interoperative decision making must be adopted and audited, and fluorescence-based mapping can be used where nuclear medicine is unavailable. Importantly, backup lymph node dissection should not yet be omitted, as the current literature remains limited in quality and maturity. Prospective randomized trials are essential before sentinel lymph node mapping can be safely integrated into routine clinical practice.
Excellent. So, Alex, we'll move to you, a topic that you have written quite a lot about, minimally invasive surgery for advanced stage ovarian cancer, a review of evidence and emerging paradigms. Alvin Matthew from Houston Methodist asking, with emerging technologies such as robotics, fluorescence imaging, ctDNA, AI-assisted surgery, do we envision a future where minimally invasive surgery expands beyond highly selected cases? Or do these tools risk widening disparities based on institutional resources and surgeon experience?
Well, to the second part of that question, I think all new technology, risks widening disparities, right? Like it's never adopted uniformly or fairly. I think that's just sort of the nature of the world that we live in. And I hopefully once it becomes more routine, then everyone gets access to it. In terms of who is going to be a candidate for minimally invasive surgery in advanced ovarian cancer, I think you got to be practical about these things. I think that clearly patients who have a great response to neoadjuvant chemotherapy are going to be great patients. I think the other group of patients that are very reasonable are folks who don't have apparent carcinomatosis on imaging. They have a mass and then end up having some small volume carcinomatosis that can be reasonably done minimally invasively, right? I don't believe that patients who have a poor response to neoadjuvant chemotherapy or patients who for some reason have large volume disease and you're going to do a primary debulking surgery, that those are ever going to be good candidates for minimally invasive surgery. And maybe it's just because of my own personal limitations as a minimally invasive surgeon, but certainly I don't see a wide role for minimally invasive surgery in those patients.
So, Renee, to follow up question to that, are current patient selection criteria like imaging, CA-125 response, diagnostic laparoscopy still sufficient to safely identify candidates for minimally invasive interval debulking? What criteria do you use in your practice?
In my view, current patient selection tools, cross-sectional imaging, CA-125 response, and diagnostic laparoscopy are helpful for predicting the likelihood of complete cytoreduction, but they are not sufficient to safely justify minimally invasive interval debulking in routine practice. At present, a minimal invasive approach remains outside the standard of care and lacks robust evidence demonstrating oncological equivalence to open surgery. We should await the results of the LANCE randomized trial, who Alex is one of the main investigators, which directly addresses this question. Beyond LANCE, available data come mainly from small retrospective or feasibility studies, which are highly selected and hypothesis generating. Until high-level evidence is available, minimal invasive surgery should be restricted to IRB-approved protocols.
Excellent. So let's turn now to cervical cancer, and we'll start with locally advanced. Article titled De-escalation in radiotherapy treatment for locally advanced cervical cancer, a historical perspective. İlker Selkut from Turkey asking, what is your opinion on the radiotherapy application during the Interlace trial in the context of modern radiotherapy with um, induction chemotherapy, would this lead to better survival outcomes, or is this a negative trial to compensate for suboptimal radiotherapy?
I mean, I feel like interlace negativity is very widespread these days. And clearly, interlace is a trial that has limitations. I think noting that, the radiation in interlace is different than state-of-the-art, CT or MRI guided brachytherapy is important, right? But I think that there's I don't agree. I think that like Interlace is a positive trial, no matter how you look at it. In the patients who are in the trial getting the kind of radiation that they got, induction chemotherapy helped. It's important to note who this population was, right? It was a largely node negative population, and to apply those data to a similar population. But I think the idea that it's not going to work with better radiation is a hypothesis. It's not proven, right? So it's possible, yes, that interlace only works if you don't have image guided radiation, and but it is also possible that interlace also does work with image guided radiation, and that the outcomes in embrace one would have been even better if there had been induction chemotherapy, right? And so I think either thing is possible. I think a lot of the criticisms of interlace are things like, well, patients didn't finish as much of the cisplatin as they were supposed to get, during their radiotherapy, which I think feel a little bit spurious to me when they lived longer, right? So I think there probably is a role for interlace in some patients. Now, I think, it's a select group of patients. I don't think it's the same patients that you're going to use immunotherapy for. But I am not as much of a interlace hater as many of my respected colleagues seem to be.
A known terminology in gynecologic oncology, interlace hater. So Renee, we'll turn to you for this question also from Milker. Since hypofractionation is used in breast and prostate cancer, what's your opinion about its use in cervical cancer? Do you think this might improve survival or decrease toxicity?
Pedro, from a gynecologic oncologist perspective, the cornerstone of cure in locally advanced cervical cancer remains timely multidisciplinary chemoradiation combined with high-quality brachytherapy. While hyperfractionation has transformed care in breast and prostate cancer, cervical cancer is biologically and anatomically different. Early contemporary studies using modern radiotherapy techniques suggest hyperfractionation as feasible and may improve access and treatment completion, particularly in resource-constrained settings. However, robust long-term data demonstrating equivalent survival and late toxicity outcomes are still maturing. Until high-quality phase 3 evidence confirms non-inferiority hypofractionation should be considered cautiously, ideally within clinical trials, ensuring that treatment intensity and overall treatment time are not compromised.
Excellent. So let's turn to a topic, March 2026. We're still talking about neoadjuvant chemotherapy in cervical cancer, a narrative review. Question comes from Nicole Chris, University of Western Australia. Alex, she's asking, has there been any correlation established between response to chemotherapy and risk of recurrence so far?
I think the answer to that question is yes. I think there are a number of retrospective studies that have shown that folks who do not have an immediate response to neoadjuvant chemotherapy have much worse prognosis, and that makes physiological sense. I think in general we see that folks with cancer that's less chemoresponsive do tend to do worse.
Excellent. Um, for you, Renee, given the response rates to induction chemotherapy in terms of tumor volume reduction, is there any role for this in stage 4A disease to minimize the risk of fistula formation?
Pedro, for stage 4A disease, where tumor invasion of bladder or rectum increased the risk of fistulation during treatment, tumor shrinkage from induction therapy is biologically appealing. Reducing tumor bulk before radiation may theoretically decrease necrosis-related fistula formation and facilitate safer delivery of definitive therapy. However, stage 4A patients were underrepresented in this trial, and fistula risk was not a primary endpoint. Therefore, while induction chemotherapy may be considered in selected cases, its use to prevent fistula formation remains individualized rather than evidence driven.
Excellent. So, last topic that we're going to cover in this podcast, de-escalation in definitive surgical management of cervical cancer. And these questions come from Leila Abuladzi in Georgia. And question to you, Alex, is in this review, you note that the intraoperative discovery of positive lymph nodes create a critical decision point regarding whether to proceed with surgery. Given the morbidity of dual modality treatment, considering that current guidelines advise against surgery in the presence of nodal involvement, what is your personal approach in this situation?
Yeah, I mean, I don't know the guidelines are necessarily biased against surgery in the presence of nodes. I think it's been sort of a guiding principle as that dual therapy is more morbid and does not produce better outcomes than single therapy. I think that that's based on obviously older data. We don't really have very compelling data about what dual modality treatment looks like with modern radiation, with IMRT and with image guided brachy, right? But we know that traditionally folks had higher morbidity if they had both. And so we've tried to avoid that, and I still do. So in my practice, if I encounter a suspicious node, like a clinically enlarged node at the time of surgery for cervical cancer, I would send that node for a frozen section. And if it was positive, I would abort doing the radical hysterectomy and move forward with definitive chemoradiotherapy.
Excellent. Very well. And as the last question, Renee, more of a general question. Layla's asking, in your review of multiple studies, was there any particular study or result that you found especially interesting or potentially practice changing?
For sure. If we're talking about practice changing evidence in surgical de-escalation, SHAPE stands out clearly. It is a large randomized phase 3 trial showing that in carefully selected low risk early stage cervical cancer, a less radical operation can achieve comparable cancer control while reducing urinary morbidity. Exactly the kind of balance between oncological and safety plus better function that changes standard and guidelines. Unfortunately, although prospectively collected GOG 278, conserve and lesser don't have the weight that SHAPE trial can have.
Excellent. So I want to thank you both so much for your time, for your very clear and detailed responses to these questions, for all the time and the effort that you put into soliciting these articles, putting them together, editing them, going through with all the authors on all of those revisions. So really impressive work. Gretchen as well, fantastic job. And I couldn't be more proud to have this special issue as my last special issue as editor-in-chief for the journal. So once again, thank you. So much gratitude for all your work. Really excited and invite everyone to take a look at all the articles that are published in this special issue.
Thank you, Pedro.
Thank you so much, Pedro.